2 chapters. So like I said, I have condensed it as much as I can possibly condense it. And I posted that on Blackboard. I think I've got, 43 slides on one, 37 on the other. It's doable. So you guys just had your first dose of medications. It's a little bit harder, right? Now we're throwing drugs and medications in. Now you have more to learn and apply it. So it is a little bit trickier. So moving toward the exam you saw today, who keeps doing that? Is that what that hook's supposed to be for? I have it. Golly. So yeah, so what you saw today, what you can expect, an idea of what the rest of the exams are going to look like, okay? So, let's just jump into 24. And I think I put skeletal something or other on there. As I'm looking through the book, they don't go through a whole lot of skeletal stuff in this book, unless I'm missing it. So, for that portion of it, not that it's a lot, I put it on Blackboard. What page did I tell you to look at?
It was 700.
705
to 706.
So, I mean, I feel skeletal is important, however, and it doesn't go through a lot of it. So, 705, I wanted just to talk a little bit about the osteoporosis, because I think that's important for men and women. So, starting at 705 at the bottom right, it talks about what osteoporosis is, skeletal disease. Typically, has anybody not heard of osteoporosis? It affects your men and women older than 50. Women, they start losing estrogen, and go through menopause, and so on and so forth. The big thing I want you to know are the interventions on 706. So really prevention of osteoporosis. A lot of healthcare is prevention, right? Prevention is that calcium and vitamin D. What do you guys know about calcium and vitamin D intake? Anything?
Build your bones.
Build your bones. How do you take it?
Milk. Your food.
Orally or food.
You can get it through food, you can take supplements, and a lot of times, maybe start having to take supplements as people get older because it's not enough. But with the two of them, so calcium, depending on the dose, it needs to be divided doses, right? So let's see, calcium for women 1950 and then 50 plus, 1,200 milligrams a day. So calcium does need to be divided into doses. You would not take 1,200 in one dose because your body cannot absorb that much at once. So 1,200 a day in divided doses, number one, for the calcium, okay? But number two, you have to have vitamin D to absorb that calcium. So if you ever look in pharmacies or whatever, a lot of the calcium supplements, not all, but most will say calcium plus vitamin D. You have to have vitamin D to absorb the calcium. So how do you get vitamin D? Sun, food, a variety, but for sure the sunshine, right? That's how it gets absorbed vitamin D. So, milk, a lot of food is fortified with vitamin D also these days. But just know that calcium, vitamin D go hand in hand. If you do not take vitamin D or get vitamin D somehow, some way, your body's not going to absorb that calcium. And if you try to take all 1,200 of calcium at one time, you're not going to absorb all that because it's too much. So divided doses, vitamin D, and then just kind of review those different sources of calcium and vitamin D, like milk, food, sunshine for the vitamin D. So be aware of that. I don't think, did I list any drugs? I don't think I listed any drugs for osteoporosis, did I?
I don't think so.
So anti-inflammatories, analgesics, I think is all I meant. Okay, so that's what I want you to know about osteoporosis in that chapter. So then I'll flip back to 24 and then we'll kind of go through some of this. Okay? Questions so far? All over the place. Okay. So anti-inflammatories is what?
It said.
It's going to fight inflammation. It's anti-inflammation, so it's an anti-inflammatory, it's as simple as that. The pathophysiology works. So inflammation is actually a protective response of our body, right? Tissue damage occurs, and then our body sends this whole vascular response to protect the tissues of our body. So a little bit of inflammation is okay, it's protective, it's our body doing what it's supposed to be doing. But if it gets to the point where it's too much, it's too painful, it's uncomfortable, we might need to suppress it and take an anti-inflammatory. So when you guys start looking up meds in your drug books, particularly analgesics, you might see something about prostaglandins in there. So like, you know, when you're looking it up, what is the mechanism of action? It's prostaglandin inhibitor. That just means that that's how it's working. That's the pharmacological way it's working in the body to control pain, okay? It's either working the prostaglandin side, directly on the tissue, so on and so forth, okay? So with inflammation, you don't necessarily need to know the vascular and delayed phase at this point. Just kind of know what it is. But what I do want you to know is the COX enzyme. I believe I gave you your drug to know. Yeah, the COX-2 inhibitor is selexicon. So here's, I think I go into it a little bit more. So your COX enzyme actually converts this little substance in your body into prostaglandins. Again, prostaglandins, you're dealing with chemicals, right? There's also protective properties with these COX enzymes. So COX-1, right? It protects the stomach lining and regulates blood pressure, or platelets. COX-2 triggers inflammation and pain. What is the drug? What is the COX inhibitor I told you to know? What's your drug? Selexicon. Okay, is that a COX-2 inhibitor?
COX-2.
Okay, so if the COX-2 enzyme triggers inflammation and pain, which is what our body's supposed to do, right? But if it gets to be too much pain, too much inflammation, we want to inhibit that enzyme. If we inhibit the COX-2 enzyme, we're going to inhibit that inflammation and pain, right? Because again, our body's normal response to pain and inflammation is releasing the COX-1 enzyme, COX-2 enzyme, but if it's too much, we have to inhibit those. So, if it's a COX-1 enzyme protects our stomach lining and it regulates blood platelets. So if we inhibit that COX-1 enzyme, what may happen?
It's not, your stomach lining's gonna be more adhesive.
You're going to mess up your stomach, right? You might have gastric irritation and blood platelets, maybe even some bleeding going on, right? Because we're inhibiting that protective COX-1 enzyme. Same with COX-2. If we inhibit that, then we inhibit the inflammation and pain, okay? So do know that.
So if you're inhibiting the inflammation and pain, you're gonna have something wrong and have no indication that something's wrong, right?
Not necessarily, but the main thing, if you inhibit it, it's going to help your pain and inflammation. But what it could do in the process is cause stomach issues, cause bleeding, if that makes sense. Okay? So, you know, remember, like everything we do, we start taking medications, there's going to be good things about medications, but there's also going to be side effects of medications. So we got to figure out how bad is it. Do we want to suppress this pain and inflammation, or can we handle it? So every med we take is going to have a side effect. So these COX inhibitors, there's your side effects. Again, it doesn't mean we're not going to take them. It just might mean we take them a different way, and we'll talk a little bit more about those moving forward here, okay? Also with pain, there might be chemical mediators, histamine. Have you guys heard of histamine? Histamine response, that's another way that our body responds to inflammation. The histamine, you think about seasonal allergies, antihistamine. Histamine's released in response. It causes inflammation. When it causes too much inflammation, we need to decrease it, and that's why we take antihistamine. So this is where moving forward, like with these drugs, I told you, as you're looking those up, what is the pharmacological class? How is it working in the body? What is the pharmacokinetics of it? And then it's gonna make more sense, those side effects and what you may or may not do for them, okay? So this is why you need to know how they work in the body, okay? Let's see here. And I've kind of tried to highlight some things for you guys to pay attention to. You do need to know some information. This is basic anatomy, physiology, and healthcare. Redness, swelling, heat, pain, loss of function. Those are cardinal signs of inflammation, 100%, okay? Let's see what I've got going. Again, I've tried to really narrow this down. Your anti-inflammatories, you've got NSAIDs, corticosteroids, DMARDs, and anti-gout, and we'll talk about those just a little bit. Action of NSAIDs, these are all the things NSAIDs do. You're going to hear a lot about NSAIDs. NSAIDs, they work, but they also have their risks, which we'll talk about. But look at that, they inhibit the COX enzyme. So you might have stomach issues. Number one issue with NSAIDs, hear what I'm saying to you. Number one issue with NSAIDs is gastric irritation, right? It could go as far as bleeding. How do we know if we have gastric bleeding? What are you gonna see?
Like with too much ibuprofen.
What? Yeah, like you might have those black tarry stools. Have you guys heard of that? Black tarry stools. What's happening is that if there's bleeding in the stomach, by the time it goes through the small intestine, large intestine, makes its way through it, it ends up being black. So the darker the stool, if there's blood in there, the darker it's going to be if it goes through that whole digestive process. So black tarry stools, maybe just pain, epigastric pain. So number one issue with NSAIDs is the gastric irritation. Be very much aware of that. NSAIDs, especially the over-the-counter ones, ibuprofen, there's your number one culprit for all kinds of issues. What happens? Nobody's monitoring it, right?
I know that.
I even have nurse friends like, well, I just took 1,200 ibuprofen. I don't know why you did that, but that's not a good idea. So the NSAIDs inhibit platelet aggregation, so that's where you could get the GI bleed, right? Because platelets are responsible for bleeding. Aggregate means clumping together. So if it inhibits those platelets clumping together, it means they can be more at risk for bleeding. Anti-analgesic is what? Analgesic effect, what does that mean?
No.
Analgesic.
No.
Pain. Pain. So start knowing these terms. So analgesic effect is addressing pain. Antipyretic is what?
Not sweating.
Fever.
Fever.
Yeah. So inhibits biosynthesis of prostaglandins. So biosynthesis means what? Creation, right? Formation of prostaglandins. And prostaglandins have a role in pain, right? So if they inhibit the prostaglandins, that's going to inhibit the pain. Because again, prostaglandins are released as a body's routine mechanism. So when it gets to be too much, so this is how the NSAIDs work. They slow the formation of prostaglandins, which is going to slow pain. They have an analgesic effect, which means they decrease pain. Antipyretic effect decreases fever. Inhibits the platelets, which could cause bleeding. It mimics some of the effects of corticosteroids, which we'll talk about here in a minute, and then the COX enzyme. Okay. So NSAIDs. There's different generations of them, right? Your COX-2 inhibitors, I believe, is your drug to know. That's your second generation. It's the newer one, right?
The Celebrex.
What?
The Celebrex?
Yes. And it's a little more specific on how it works than your first generation. So there is a place for it, for sure. And we'll talk about that, I believe, here. Your salicylates. Aspirin. You guys have heard of aspirin, right? Yes? Not
Yeah.
heard of aspirin? This is one of your NSAIDs. So anti-inflammatory, non-platelet antipyretic. What I want you to know is that there's levels with aspirin. Aspirin can be a dangerous little thing there. 15 to 30, that means it's therapeutic. That's the blood range. If it's between 15 to 30, we're okay. It's working how it's intended to. But patients, people can become toxic from aspirin. Is aspirin over the counter?
Yeah.
Yes.
Low dose.
We should worry about that, right? Aspirin can be a nasty little thing. Aspirin is not really meant for long-term use. Have you guys, I don't know, you've probably not read your chapters yet. Signs of toxicity that a patient might report with aspirin might be tinnitus. What does that mean?
Ringing in the ear.
Ringing in the ears. If you have a patient that's known to take aspirin and they're complaining of ringing in the ears, we might want to get a blood level drawn, right? So greater than 30, they say, is mild. Severe is greater than 50. But the big thing, so you need to know that, but you also need to know if a patient is complaining of ringing in the ears and we know they take aspirin, we need to check it out and get some levels drawn to make sure they're not toxic from it. And patients will take aspirin for all kinds of reasons. Headache, menstrual cramp.
They had me on it when I was pregnant to prevent in the early term.
Yeah, we'll talk about aspirin for pregnancy here in just a minute. Did that came COVID? Anybody pregnant during COVID? They started that funny thing of putting pregnant women on aspirin when they got COVID. But okay. To me, it made me a little nervous. Like y'all don't know enough about COVID and all this, but you do you.
Mine was due to I had prior history with
Blood clots or something.
amniochoritis and early pregnancy loss.
Yeah.
So they did that to prevent any blood clots
Yes, and there
early.
are some reasons for it, but usually it's going to be somebody with a genetic defect or known history of something they've had with pregnancy. But in general, you got to be careful with salicylates and pregnancy. Some interactions with other anticoagulants and NSAIDs. What I do want you to know, again, they inhibit platelet aggregation, so they can cause some GI bleeding, right? One thing, there is something they have for aspirin. So first of all, people should take aspirin at least with a full glass of water, right? Maybe they can't take it with food or whatever, at least a full glass of water. So if you have patients that maybe it's still causing some heartburn or some epigastric pain, something like that, they could go ahead and give them enteric-coated aspirin. You guys heard of enteric-coated aspirin? What does that mean?
It has a lining on it.
Hard part around the aspirin.
Right, which are never supposed to be crushed or scored or anything like that.
Or broken.
It's got a little bit protective. It might help a little bit with the lining of the stomach. Do not take aspirin with other NSAIDs, okay? It's going to decrease blood level and effectiveness of the NSAIDs. Aspirin NSAIDs shouldn't be taken together. That's a general rule. So again, it inhibits a COX enzyme. I don't know what I have on here. It inhibits that COX enzyme, so it kind of inhibits that COX-1, which protects the stomach lining. So because it's inhibiting that, it's going to cause more gastric irritation. Where the COX-2 enzyme does what?
Or pain.
Yeah.
Pain inflammation.
Pain inflammation, yeah. So again, so aspirin kind of works with both COX-1 and COX-2. So when the COX-2 is inhibited, again, pain and fever are reduced. And one thing about NSAIDs in general, they have the property of the anti-inflammatory. Or like your acetaminophen, which is not an NSAID, which I'll talk about in a minute.
That's
doesn't
just
have
pain and fever.
anti-inflammatory. That's only
Pain
for
and fever.
Pain and fever, right? So NSAIDs have that extra element of being an anti-inflammatory, and it's that extra anti-inflammatory element that causes issue with the stomach because of that COX enzyme it's inhibiting. Are you following me so far? Okay. Super important to know. It really is important to know. So don't take it with other NSAIDs. Last trimester of pregnancy, we should not be taking them. It could cause some adverse effects on the fetus. And specifically, it caused premature, and you guys will get to that when you get to the OB. There's a duct
Abruption.
in the heart that causes it to close early before it's supposed to. So it can cause significant issues in the unborn baby when taken in that last trimester. And that was the thing, like I said, when COVID was all crazy, they're like, oh, these doctors, women that were pregnant were having them take aspirin if they got COVID while they were pregnant. And I had a couple friends that were like,
I was only directed to take it for like the first, I want to say 20 something weeks.
they were just doing it when they were getting
Until it
pregnant.
was viable. I want to say 21,
Yeah.
22.
Yeah. No, for them with COVID, they were specific because people with COVID were having blood clots. But it's risky. It was risky business. Risky business. A lot of women were like, I don't know. I'm told that aspirin can cause birth defects in the last trimester. So then they were forced with this decision of, do I risk a blood clot? What am I going to do? So it was kind of crazy. But last trimester can definitely cause some adverse effects on the fetus. So really should probably avoid that. Aspirin is not uncommon to use that for arthritis, and there's a prototype chart on 282. Can cause dizziness, drowsiness, headaches, and again, if a patient complains of tinnitus, that ringing of the ears, they might be toxic, which could eventually lead to hearing loss. Like you're ringing in the ears, that is not a good sign, right? If we don't address it, they can end up with hearing loss. Again, with the GI distress, are you guys getting what I'm saying in the GI distress? I cannot stress it enough. What I do want you to know about aspirin is Reye's syndrome. You guys ever heard of that? R-E-Y-E-S. It's this little syndrome that children with viral infections can get if they're given aspirin. Kids with viral infections should not be taking aspirin. And you guys, have anybody ever heard, oh, I just take a baby aspirin? If we could stop with that terminology, that would be great. Years ago, kids used to take aspirin, and they used to have actual baby aspirin. It was little orange chewable stuff. I was a child that overdosed on that. Took a whole, I ate it all, so yeah, it's probably what's wrong with me. But they actually did have baby aspirin. But then what they found was this correlation that we're giving these kids this baby aspirin when they have viral illnesses and getting this Reye's syndrome. It is rare, but it can be deadly. They can have brain swelling, they could die. So what they've determined is no more aspirin for kids with these viral illnesses, no more, right? So now I get just cringe a little bit when I, get med lists for patients, and I take a baby aspirin. There's no such thing as baby aspirin.
Low
It's
dose.
called low dose, okay? So 81 milligrams, that's called low dose. Those are people that might be taking it because they've had a heart attack or a stroke, and they're just taking a low dose to prevent another heart attack or another stroke. Low dose, okay? 81 milligrams low dose, not babies. Do not give it to children for their viral infections. There's other things we can give them, and aspirin does not need to be one of them, okay? But again, it is pretty commonly used for arthritis. When I say arthritis, I mean osteoarthritis. There's a difference between osteo and rheumatoid arthritis, and I feel like I addressed that coming up somewhere here in one of these slides. Don't get confused with osteo.
You can have rheumatoid at a really young age too, can't you?
It's not as common, but you can. Rheumatoid is an autoimmune disorder, where osteoarthritis is basically your bones just broke down, you wore yourself out, you just all these athletes now, they can suffer when they get older. That just comes with time and use and abuse of your bones and your joints versus rheumatoid is autoimmune, so treated differently, so don't be confused with the two. Let's see here, you guys can read through that. Again, you're going to monitor the serum level, especially if they tell you they have ringing of the ears. But patients that might take this for arthritis and take it routinely, we should monitor some levels if they're taking it all the time. Again, evidence of bleeding. What would evidence of bleeding be?
Occult feces?
You could have blood in your stool. What else? Stomach pains. What else? evidence of bleeding?
Blood.
Bruising, bleeding gums, all those different, they shave, they keep bleeding. Just be aware of those. Do not take aspirin with alcohol or warfarin. Dang alcohol again, right? And warfarin again, I know you guys have not gotten to this yet, but that is a blood thinner, okay? So aspirin and a blood thinner together, probably not the greatest idea. We'll talk more about that later when we get to warfarin. Instruct patient to discontinue it about 7 days before surgery to reduce the risk of bleeding. This is quite common. So again, aspirin's an over-the-counter med. So you need to ask patients, if they may not know what they're taking, okay? So if they're gonna be having surgery, get that list of what they're taking, and you might even physically ask, do you take aspirin or any other blood thinners? You're gonna need to stop that 7 days. Why do you need to stop it?
So you don't bleed.
Cutting into them, what happens when we cut into somebody? We bleed, and we're gonna bleed even more, because what aspirin does is keeps those platelets from clumping together. It just keeps them going. They don't clump, so you don't have that clumping, so they can bleed excessively. Okay, so that is an important piece. Again, no aspirin for children or flu or virus, any virus. Just really just keep aspirin away from kids, period. Just take this thing. Don't use it. They don't need it. They don't need it. Okay? Let's see here. Call Poison Control Center if child is taking a large or unknown. Yeah, you should. One, keep it out of the hands of children. But if they get it, which they can, poison control. Another thing with aspirin, teens, try to off themselves either with aspirin or acetaminophen, try to commit suicide. This is over-the-counter stuff. You can buy it easily. So both are up there on the list, aspirin and acetaminophen, which we'll talk about acetaminophen in a minute. Okay, parachlorbenzoic acid. Did I give you a drug to know for that? I don't know if I did or not.
No.
Okay.
Well, no.
No? Okay.
Because it's the ibuprofen's the propionic acid, right?
Yes.
Then no.
Okay, but that's okay. But do know that there's some things we can use it for RA, osteo, or gouty arthritis. Kind of know that. Phenylacetic acid derivative. What in the world? Rheumatoid, osteo, ankylosing spondylitis, and pain. It can be used for all those. I believe ketorolac is your med for that.
I don't think we have one for that one either. Here's the list. It says just the next one is the ibuprofen. It doesn't have anything for 2, 3, or 4.
Okay. Okay, well, for this one, I do want you to know ketorolac. It's probably, I should have given that to you as a drug, but that's okay. You don't necessarily have to do a drug card on it, but you need to know the drug. Ketorolac. I am on page 283. Bottom right, under phenylacetic acid derivative. Ketorolac. Have you guys heard of Toradol?
I feel like
Okay. So it's an injectable. Okay, it's not a pill. It's injectable. It can be given IM, but more commonly given IV. So the generic name is Ketorolac. The brand name is Toradol. It inhibits prostaglandin synthesis, meaning it's going to inhibit those pain receptors to begin with. It actually has greater analgesic properties, analgesic meaning pain, right, than other anti-inflammatory agents. So, what I want you to know about it is this. It is short-term management only. This is not long-term, it's only injectable, either IM or IV. Short-term management. So what we've learned about this ketorolac, it's routinely used for post-op pain, but usually they'll say stop it after 24 or 48 hours. They'll have a stop date on it. After that, we're done. It's really just for that immediate post-op pain, and it's actually pretty superior than opioid analgesics. It works quite well. They use it in combination with other medications as well. They might give this, they might give some acetaminophen, combo kind of thing, but it is actually superior than opioid analgesics in many cases. So maybe they don't need morphine after surgery. Sometimes just simple ketorolac and or acetaminophen can help that post-op pain. So you might get those patients, I don't want narcotics, I don't want that stuff, I don't want to be addicted, which they're not going to be addicted from 1 or 2 times, but you might have those patients that do not want those opioid analgesics. They don't like the way it makes them feel, they just don't want it. We have this as an option, okay? And it's a very good option. Just know though, it's short-term pain, and usually it's going to be post-op pain. Sometimes you see it ordered for other things.
I feel like I've had Toradol for like a car accident.
You may have, yeah. You may have, and right now there's a national shortage on it, FYI. But do know, short-term, it has been shown to be equally as effective as opioid analgesics, and it's good for those patients that do not want narcotics, because everybody doesn't want narcotics. And when used for post-op pain, typically at 48 hours, we're done, right? But at 48 hours of post-op pain, you should not be having the post-op pain after 40 hours like you would initially. It's going to be much higher, right? Okay, are you guys following me? So I do want you to understand that on the ketorolac. Ibuprofen. What? It is the most widely used NSAID. Has anybody never heard of ibuprofen? I'm telling you what, guys, it works, but it's dangerous. It's some bad stuff. It can cause some damage. Antipyretic is for what?
Fever.
Analgesic.
Pain.
And this one has the anti-inflammatory properties as well, okay? It inhibits prostaglandin synthesis. You might see it used for just pain in general. Sometimes patients will use it for osteoarthritis and maybe sometimes rheumatoid because of that inflammation that's going on, okay? So it's got that added anti-inflammatory property that the acetaminophen does not happen to have. Gastric distress and bleeding, again, I really want you guys to read on that. I think it's 277 through 278, that pathophysiology of the pain. Again, it's going to stress and go over the inflammation process and those COX enzymes. So really read that and understand that. It's going to help you understand how these work. So gastric distress and bleeding. Peripheral edema, what does that mean?
Fingertips, toes, the numbness, tingling, nerve.
No, just the edema. So just
Oh, the
edema
swelling in the
yeah,
water.
It could be your ankles, wrists, peripheral, in the periphery of it. That's hands and legs. So
I was
a lot of
thinking
times
neuropathy.
It's okay. Ankles or wrist, or yes, you can have it in your hands as well. But they are common side effects of NSAIDs.
So would that make it more like for a precautionary drug, like if you're diabetic and stuff and you want to avoid injuries to your feet and
Well, that's not going to cause injuries to your feet.
But with the
itself. But they
edema.
could sometimes interact with hypoglycemic agents. But the swelling itself shouldn't cause injury to your feet. But that's just a common side effect. And it doesn't mean never, ever, ever, ever take it. Just don't take it all the time. You might need to take it here or there, or maybe you're not feeling well or an injury or something. You take it for a short amount of time in the appropriate doses. Okay. Bleeding gums. These are all signs of bleeding. Those bleeding gums. Petechiae. Do you guys know what petechiae is yet? They're like little. Yes, like red spots all over your body. That's a sign that there's some decent bleeding going on if you have that. Ecchymosis really just means bruising. It's like black tarry stools. Avoid alcohol when taking NSAIDs. Some complementary therapies could interact with them if it's a complementary therapy that, I think, let's see, page 285, there's a little chart there. Dongquai, fever view, garlic, ginger, ginkgo. Ginkgo's one I'm going to hone in on there just because ginkgo is used pretty commonly
What page?
It can cause excess bleeding. So if somebody's taking ginkgo, people take ginkgo routinely, like for memory or for whatever, they should not be taking the NSAIDs with that, okay? So avoid those things, those CAM therapies if they need NSAIDs. Don't take them together. We don't want excess bleeding. Again, remember a lot of those things we use, these complementary therapies, they come from nature. A lot of the drugs we have come from nature, so you can have an increased reaction, okay? Venomase. Where am I here? Usually these are more for arthritis a lot of times. One thing about phenomates, and I'm on 284, patients with peptic ulcer disease should not be taking them. You guys know what peptic ulcer disease is?
Ulcers in your stomach.
Basically, if you had bleeding ulcers in your stomach, okay? It can be pretty serious, it can come back later. So these just stay away from them, okay? That's all I want you to know on that. Oxycams, I don't think, I'm gonna skip through that. The COX-2 inhibitors, your Celebrex, Lexapro is your drug. And again, this might be for osteoarthritis, rheumatoid arthritis. It is a newer generation NSAID, so it's a little bit better than the others. Typically, this is going to be a prescription NSAID. So it could be that patients are taking ibuprofen for their, arthritis or whatever, and they're finding it's just not helping. Usually the answer is not, so this is what patients do taking the just say ibuprofen. Take an ibuprofen for osteoarthritis. It's not working, so I'm gonna take it. Let me go ahead and double the dose. Let me just triple the dose. More is better. No, if it's not working, the answer is probably to get maybe a COX-2 inhibitor or something different, to talk to their provider about it. Don't just keep on increasing the dose of it. If you're taking the recommended dose and it's not helping, then we need to look at something different, okay? Or sometimes it takes a little while for stuff to start working too. Because what could happen with NSAIDs is, I've been taking it 2 days and it's no better. Well, osteoarthritis is usually a lifetime effect of, it's probably not gonna get better in a day or two. Sometimes you have to give things a chance. Sometimes 2, 3, up to even 4 weeks sometimes. Give it a chance. And then after 4 weeks, if it's still not working, the ibuprofen, we're not gonna increase the dose, we're gonna maybe try this one, okay? So 1, you gotta give it time to work. 2, take the recommended dose. 3, increasing the dose is not gonna help, you just need to look at something different if it's not working. So those 3 things are important when you're talking about NSAIDs. Okay, so your selective COX-2 inhibitor, again, that's gonna decrease inflammation and pain. And again, I'm gonna let you guys read that without me reading it to you. On 285, it goes over it just a little bit more in depth. Your selective COX-2, read through that. Select your drug to nose on page 286, but really understand that little piece at the bottom of 285. I think that will help you. I do want to talk about NSAIDs in older adults. Drug interactions are more common just because as patients get older, they're taking more drugs, right? That's just the way it goes. We get older, take more drugs, they take one drug, there's going to be side effects, they're going to take drugs to counter effect the side effects of that drug, and so on and so forth. So we have polypharmacy. So it would stand to reason they're more at risk for drug interactions because they're taking more drugs. GI distress is the most common. They up to really ulceration. I've seen people take so much ibuprofen they've had to get blood transfusions. If they start having issues, GI distress, epigastric pain, there could be an issue going on. We need to investigate and make sure we're not having ulceration or bleeding that's going on, okay? And again, more so in older adults because they're taking more medications. Let's see here, corticosteroids. Okay, corticosteroids. I don't want to get deep into this because it can be confusing, but one thing about overuse of corticosteroids is you can damage adrenal glands. If we overdo it with corticosteroids and we do not slowly come off them, you can suppress adrenal glands, you can cause diabetes, you can cause all kinds of issues. So the big thing with them is, have you guys taken steroids before? Probably maybe for respiratory illnesses or throat issues or whatever. Usually there's going to be instructions to take over 10 days. Day 1, take whatever, 5 pills. Day 2, take 4 pills at this time. Day 3, and then you start off with a bigger dose and you slowly, day by day, have less and less. That's called tapering off. Tapering off means each day you're going to have less of a dose, because otherwise if you just take this big old dose and then stop cold turkey, it suppresses your adrenal glands and they can cause some real damage, okay? So also with the corticosteroids, we can use them for arthritis flare-ups. Typically they shouldn't be used long-term because they can be dangerous, okay? It's really not the drug of choice for arthritis, because what do we know about arthritis?
Nerd.
It's chronic, right? Right. So to give, it's not just a one-time deal, it's chronic. So we shouldn't really be taking steroids for chronic condition because that means long-term. But occasionally, if they have a horrible enough flare-up, occasionally they might order a dose of corticosteroids to get them over that hump, but still tapering off over the 5 to 10 days because it could really cause damage otherwise, okay? So that's the biggies on the corticosteroids I want you to know. DMARDs. Okay? DMARDs. Disease-modifying anti-rheumatic drugs. It's disease-modifying. It is not curing the disease. Let me be very clear. You are not curing this. And I think this is one of your drug cards, your infliximab. For rheumatoid arthritis, that is an autoimmune disorder. Right now, there's no cure for it, okay? This is just gonna modify the disease that's happening. So basically, the big goal we have is slow the progression. Have you guys ever seen anybody with rheumatoid arthritis? Or somebody that hasn't really been treated with rheumatoid arthritis? Oh my gosh, they're just so, they can be just completely crippled up and not, it's horrible. So the goal is for them not to get to that point, just to slow the progression of the disease. And we're seeing younger and younger people being diagnosed with rheumatoid arthritis now. It's crazy. But again, so what this does, so it's an autoimmune disorder. So autoimmune means my body is attacking itself because of this disorder. So in order to stop my body from attacking itself, I need to suppress my immune system, right? Because the autoimmune disorders, the body's recognizing a disorder, saying, oh, there's something wrong, I'm gonna attack you. It's just all over itself. We gotta suppress that. So if we suppress our immune system, what are we at risk for? Other infections, right? So when they take these immunomodulators or DMARDs, whatever you want to call it, it decreases their immunity because we're suppressing the immune system. So patients should have routine CBCs evaluated. What's in a CBC that we're concerned about? Yeah, mostly your white blood cell count. So if they are on one of these immunomodulators, they need to routinely have lab work drawn to make sure they're not so low that they are at risk for getting other diseases. So again, it slows progression of the disease. It does not cure it. They're going to have routine labs done to make sure their immunity is not too terribly low, that they're going to catch everything under the sun. Also, these are patients that, they probably should get vaccines and things like that just to make sure they don't come in contact with things, okay? Anti-malarials, let's touch on that. We already talked about anti-malarials, right? Does that sound familiar? Should. Sometimes, rarely, they might use that for RA when all other treatments fail. So the only time you're going to see that, they've tried everything else. you might occasionally see an anti-malarial used for RA, if nothing else worked. There's so many different medications out there now though for these DMARDs for RA and other autoimmune disorders. So typically they shouldn't need it, but there's that slight chance that they have nothing else left, so we're gonna do anti-malarial, and it might help lessen the symptoms. Okay, so what's the difference between osteoarthritis and rheumatoid arthritis?
Rheumatoid is autoimmune.
And also the bone.
Yeah, and more commonly the osteoarthritis is gonna be your adults and your older people, because again, it's from years of wear and tear on the bones and the joints. So yes, so osteoarthritis is more physical versus RA, which is autoimmune. Okay, so understand this concept with your DMARDs. They can also cause elevated hepatic enzymes. What does that mean? Liver, so we might probably be looking, yep, the liver function tests, which are the AST, ALT, have you guys learned that stuff yet? Yeah, so start paying attention to stuff like that. So we might be doing liver function tests, we might be doing their WBCs to check on their immunity. Now we gotta check on their liver too. It's very important to make sure that we're not knocking their liver out or exposing them to everything else under the sun. So it's a balancing act. And sometimes they might have to just adjust doses too, depending on what their liver enzymes are or their white blood cell count. You guys can read that on your own. Osteo, oh there you go. Know the difference between these two, which is what? I'm gonna skip through this so we don't totally run out of time. You guys are gonna have to do some of this, on your own. Like I said, anti-malarials really is gonna be rare when nothing else works for RA. Gout, okay. Gout. Page 288, gout is worth mentioning. You're gonna hear a lot about gout. You're gonna see gout on your boards. Does anybody not heard of gout?
It's extremely painful.
Heard of it? Maybe don't know what it is.
Heard of it.
So essentially, now not always, but usually you hear of it occurring in their big toe. Big swollen toe, horribly
Painful.
You're thinking, my God, is this a swollen big toe?
The
It can
nerves.
be really painful, and it maybe it's not just in the big toe. I've actually seen patients with little crystals underneath their skin and their joints. So what happens is uric acid accumulation. It creates like these little crystals. So imagine crystals in your big toe or just like under your joints, just
Grinding.
painful. Just grainy, crackly thing. They shouldn't be there. Okay. So it is a defect in purine metabolism. The body is unable to metabolize purines. What the heck are purines? Well, there are foods that contain purines. So a simple thing to prevent a flare-up would be what?
Diet.
Diet. There's so much in life that we can control with our diet, people. And this is one, if you have known gout, well, my goodness, you know that it is a defect in purine metabolism. And you know that if you eat foods that contain purines, it's going to
Alcoholics.
accumulate. So look at what we want to avoid.
Alcoholics.
Dang alcohol. God dang it. Beer. What? No beer for you. Organ meats. I could live without organ meats. I could live without sardines. I could live without a lot of this stuff. But there are people who like their salmon, gravy. I like gravy. I don't know about that. Herring, never had it. Liver, yeah. So they're, these are the main ones. These are the highest in purine. So it's not like you can live without some of this stuff. I don't know, some of those beer drinkers though, I'm not sure. So really and there's a much bigger list than this. I don't even know if the book lists it or not. Avoid foods that are high in purines. That's going to help prevent flare-ups. Is that going to cure it? No, it's a defect in the metabolism. It's not going to cure it, but it sure is going to help from it flaring up, right? So anti-gout drugs, what do they do? Well, it's going to decrease the uric acid synthesis. What does synthesis mean?
The way it breaks down.
Formation. Synthesize something that's formation. So these drugs is going to decrease the formation of uric acid to begin with, okay? Big things with them, skin rashes. That's a big common #1 reaction you're gonna see to these anti-gout drugs is the skin rashes. And also, I think your drug of choice is allopurinol, I think, right? So to talk about that, if a patient's gonna start on allopurinol, first thing you need to do is get their serum uric acid level before you start it, okay? People will say, well, I'm concerned about their high level. Well, that's why they're gonna take allopurinol. So you need to get a baseline. So draw their serum uric acid level. That's their baseline before they start taking the meds. Why before they start taking the meds?
So you know what it was at, so you'll know where it's at.
Right. We need to know where you are to start with before we start the meds. So we'll get that baseline serum uric acid value, and then they'll start on the allopurinol, and then after a certain time, we'll draw some more labs. Let's see where we are. What is your serum? We would hope the serum uric acid level will be down once they start taking it. So allopurinol, read my notes, is for long-term management of chronic gout. Long-term management of chronic gout. That does not mean when they're having an acute flare-up, this is what they take. That's not what it's for.
Every day.
So your allopurinol is your kind of like your maintenance med to prevent that so much of that forming in the first place. There is a different med for acute flares, which is not one of your drugs to know, so I'm not going to confuse you right now. What I want you to know with allopurinol, first line, long-term management for chronic gout to prevent that formation of the uric acid to begin with. Does that mean they're never going to have flare-ups? That does not mean that. This is kind of what keeps it at, kind of at bay. But then, their diet might affect things, and they could still have acute flares. So this is what I want you to know about allopurinol, okay? So also, skin rashes, and we're also going to throw in yearly eye exams. Visual changes can result from prolonged use of allopurinol. Is allopurinol going to be something that they have prolonged use of?
Yes.
Why?
Because it's for chronic.
It's for chronic long-term management, right? So they definitely need to have yearly eye exams. So it can also cause kidney and liver dysfunction, okay? So they need to have their renal and their hepatic functions tests, yearly eye exams. Why do we want to increase fluid intake? Flush that stuff out of the body. Almost everything. Proper diet and increased fluid intake. Those are like two common things that people can do better. So, increased fluid, because again, there's like little crystals forming. So anything we can do to flush the system out and get those crystals out, do that, okay? So rash most common, yearly eye exams, monitor for their kidney and renal function, and make sure they increase their fluid intake. Not just what the average person, they need to have increased of what the average person would have on fluid intake and really flush that system out. Skin rashes, is that the same slide I had so much? Anyway, skin rashes, and whoo, that was marathon, okay? Well, I've got what? 10 minutes, 9 minutes. You guys with me so far? You with me? And again, I've tried to condense this down the best that I could. I looked at this over the summer just to knowing this was coming with you guys having days off. So I think this is doable if you read this and just pay attention to what I'm telling you to know here. Okay? So chapter 25, G6. Pain. Why is pain the 5th vital sign?
I told you there's something wrong.
Yeah, give me
It could
more.
also increase certain vital signs.
Yeah, pain affects your other vital signs, right? Pain can affect your heart rate, it can affect your blood pressure.
Your temperature.
So,
Can it affect your temperature too if you have inflammation with it?
not so much, not the pain itself, not so much. But it can affect all your other, your other vital signs. There's pain tolerance. Different people have different tolerance to pain. There's some you're thinking, my God, what kind of a wuss are you? And then there's other people you're thinking, whoa. So one thing too with pain, you need to look at physiological cues, right? What do I mean by physiological cues of pain?
With your expressions
That's a physical.
or
Physiological.
Okay.
What happens with pain? You said it affects other vital signs, right?
Your heart.
So heart rate might be elevated, blood pressure might shoot through the roof. Those are physiological manifestations of pain. So you might have a patient telling you, like an older people or Amish people, or sometimes they tend to be more stoic. Like I'm asking you your pain level, and you're telling me, oh, it's a 2 out of a 10, but you're laying there, like your blood pressure is high, your heart rate's up, your respirations may be up or down, depends on the kind of pain, right? So it might be like, okay, your subjective pain, there's subjective, there's objective, right? So the subjective, they're telling you I'm 2 out of 10, but
Objective is what
objectively,
you
I'm
see.
looking at the physiological cues, and I think you're in more pain than what you're telling me you're in, okay? And then you have the opposite, right? Oh my God, I'm dying. It's like, it's just a splinter, it'll be okay. And so it could be tolerance as well as, there's a lot of things that go with it. It could be exaggeration, tolerance, all kinds of things, right? So you really have to get used to assessing your patient. And really, like patients with surgeries, it's a good idea before the surgery. Okay, before you go into surgery, let's talk about where we want your pain to be after surgery. What's a tolerable level for you? Let's figure this out, okay? There's analgesics we can give, opioid and non-opioid. I'm not going to go deep into these different types of pain. That can be a little bit deep. But up to 75% of patients have unrelieved pain. There's difference for reasons for undertreatment. What do you guys think some of those reasons might be?
Addiction.
Addiction. What happens if somebody's addicted to drugs?
You don't want to give it to them.
Well, their tolerance goes higher, right? So if you're addicted to drugs and you're not addicted to drugs, 2 milligrams of morphine might work just fine for you, but it may not touch your pain because you were so used to having a higher level of drugs in your body. Super important to know if your patients are addicted to drugs and using. Most times they're going to tell you the truth, and you need to have the conversation. I need to know because post-op.
Well, they're going to want you to give them more.
Well, they will, and is it appropriate to give them more?
For their pain.
It is. This is why it is appropriate. And this kind of bothers me a little bit when I hear, oh, they're a drug seeker coming in the ER. They're a drug seeker.
You're there
Well,
to treat them. It doesn't.
We are not there to judge. And by the way, like post-op, oh, he's a drug addict. He's a drug seeker. Well, then you should understand if he's a drug addict,
He needs more.
he's going to need more. And our right now our obligation is to treat the pain. I'm not going to cure him these 2 days of his drug addiction 2 days after surgery, and that's not what I'm doing. But what I do want to do is control his pain. They don't deserve to be in pain any more than anybody else does, right? So you just guard against that out there. People, wow, he's just seeking drugs, or maybe he hasn't disclosed that he's addicted to drugs, and they are labeled as drug seekers when in fact their pain is just not being controlled properly. So you got to have conversations with people. We should have unrelieved pain for the most part. Now, that being said, what also gets under my skin is the surgeons that tell their patient, oh, don't worry about when you go up there. They'll make sure you're completely free of pain. That's not reasonable, okay? We just rip the hip out, saw it, cut, put screws in there. It's not reasonable, depending on the type of procedure, that they will be in zero pain. That's when we talk about what is tolerable. You're going to have some pain. What's tolerable? What do we need to do to make it tolerable for you? Okay? But really, we should not have that much unrelieved pain. And again, I don't mean zero pain. I just mean relief, right? And effects of unrelieved pain are many, right? It can cause so much trauma to the body in general. So non-opioid are obviously less potent than opioid. For your opioids work more with your brain, right? Anything that's an opioid analgesic, it's affecting how your brain is connecting pain. So anything that is working in your brain is going to have higher risk for sedation, respiratory depression. Why? What is your brain responsible for?
Pain.
Sending out the
chemicals?
Yeah, your pain is responsible for your breathing, right? It picks, your brain is responsible for those respirations, your pain is responsible for thermoregulation, all kinds of things. Your brain is responsible for your bowel control, right? So have you guys heard of opioid-induced constipation? So anything that works in the brain, the opioids, respiratory suppression, sedation, constipation, those are all risks with opioids. Opioids come with many risks, which is why they're looking at, hey, you know, those post-operative, what's that med we can give instead of opioid for pain? Right, it's an NSAID, right? It's worth it because opioid-induced constipation, plus they just had surgery that slowed everything down from the anesthesia, they're at high risk for constipation. So the non-opioids, they're less potent, they just work kind of a different way. They're more for mild to moderate pain. Not really gonna help it if we let the pain get to severe pain, we're probably gonna have to head to an opioid, okay? NSAIDs, again, I want you to pay attention to those. I'm gonna skip through this here, we've got a couple minutes. These are all things I've said before. Same thing, I'm gonna keep hitting on that. Read through those. Aspirin, this should all look familiar, right? So I mean, these two chapters kind of go hand in hand. Acetaminophen, not an NSAID. It does not have the anti-inflammatory property. Maximum dose is 4 grams per day. Do not exceed that. That can cause liver dysfunction. So remember I said acetaminophen and aspirin, this is another one of those drugs teens might use to commit suicide or attempt to commit suicide. And when they're not successful, it is quite terrible for them. Causes liver issue, all kinds of stuff. But do know, we're talking like adult size people, teens, adult size. 4 grams per day is the maximum dose. Why do you need to know that? If you're the one administering that, you need to pay attention to how much this patient has had already. And sometimes there's alerts, sometimes they're not, depending on where you work, like, oh, wait a minute, they've already had 4 grams today. I can't give this. We need to look at something else, right? Or maybe you might review doses that are ordered. Acetaminophen every 4 hours, blah, 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 blah. And you do the math like, well, wait a minute. If they can have it every 4 hours, this is gonna put them to 4.5 grams per day. Nope, we need to lower the dose or change the frequency. Make sense? Very important with acetaminophen. Know that. Again, your liver dysfunction, liver enzymes. I think you guys are gonna be able to read through the rest of this. Except morphine, that's your opioid analgesic. That is in your book as well. Check for drug allergies, check for the type of pain. Opioids with St. John's wort. That is on $2.99. Don't do it, okay? St. John's wort can increase sedation. So if the patient's having a surgery, we sedate them, right? We give them meds to sedate them. If they are taking St. John's wort, that can increase the sedation and it can become very dangerous. So they need to stop taking that St. John's wort before surgery.
On the next page, it says it decreases the drug levels of oxycodone as well. So does that just making it less effective?
Yes, it can, right? So again, these CAM therapies, we need to know what they are. Itching, I want you guys to understand this about morphine. I kind of remember what I said about vancomycin and red man syndrome. I did a quick peek already on the exam, and some of you guys did not listen to what I told you about that. That was not an allergic reaction. So now I'm going to say this with morphine. Itching. That's not an allergic reaction. That is a common side effect of morphine. Itching. Not rashes, not hives, they just itch. Okay, that is not an anaphylactic reaction. It's a common side effect. Just itching. Again, assess your patient. Are there rash? Are there hives? None of that. No, just itching. Okay. That's a common side effect. We'll let them know. We could give them something to counteract that. The naloxone is the antidote to reverse overdose. We don't give naloxone because they're itching, right? Don't do that. What happened? Do you guys know what happened? So naloxone is a reversal agent. So if we're giving them that morphine and then we reverse that, what do you think is going to happen?
You're gonna mess with their heart.
They're gonna be mad.
Well, they're going to be mad. That pain is going to come back with a vengeance. Okay. So the naloxone to reverse respiratory depression. We can inadvertently overdose people. It doesn't mean we did anything wrong, they just can't handle it. Respiratory depression, that means they're breathing 2 or 4 times a minute. That's not good. No, like, we need you to breathe, so we're gonna have to reverse it. Now, the pain's gonna come back with attention, but we also need you to breathe, okay? So it's either you die or you have the pain, and now, are you guys following me? So do not be confused with respiratory depression antidote versus the side effect of itching. Don't give Narcan because they're itching. Don't do that. Meperidine, don't worry about this. I don't care about that. I think it's a crap piece of drug or whatever. Don't worry about that one. Hydromorphone, just kind of know concepts of these. And special populations. Nubane, that's kind of one of those things they sometimes give for itching. I didn't stress a lot of this. You can kind of go through some of these. So again, I have done my very, very best to shave it way, way, way down because we don't have lecture next week, but it's doable. It's doable. Not a ton of drugs, so your drug cards will do those. I have these slides posted for you already. Drug card slide review, you can do this. Because when we come back in 2 weeks,
We have another
there's an
exam.
right? Woo!